Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. We are going to start our series of lectures with acute appendicitis. Acute appendicitis, we are going to talk about several things. We will touch on the anatomy, we'll tell about the definition, the pathophysiology of the acute appendicitis, the etiological factor or causes, and the clinical approach, which is the most important thing. And at the end, treatment and the complication of acute appendicitis, before treatment and after treatment. And we will send in later days questions about acute appendicitis. Let us start our lecture. Definition of acute appendicitis is an inflammation of the vermiform appendix, commonly in adolescent and young adult. Appendicitis is an inflammation of the vermiform appendix. Is typically present acutely within 24 hours of onset, but can also present as a more chronic condition, and it may present chronically on and off. The anatomy of the appendix, it is part of the gastrointestinal tract. It is a blind loop. It is attached to the cecum, the infromedial part of the cecum. Sometimes it is in the pelvis, retrocecal, or in the paraleal area. And due to its various positions, it can present differently. It is formed of dense lymphoid tissue. The same gastrointestinal anatomical structures are present there: the serosa, the muscular layer, the muscularis mucosa. But the difference is that it has a dense lymphoid tissue. As we said, it might attain many positions. It could be in the pelvis, or it could be paracecal, or could be retrocecal, or perialeal, and it varies in lengths. The topographical anatomy of the appendix, that means superficial on the abdomen, how to have the landmark to position the position of the appendix. If you draw a line from the umbilicus to the anterior superior iliac spine, and 1/3 from the anterior superior iliac spine, that point which trisects that line, this is what we call the McBurney's point, and it is deadly above the appendix. This is one of the landmarks which are important in the examination of acute abdomen or acute appendicitis. The pathophysiology. In the pathophysiology, we have to talk about the incidence, the age distribution, and the sex, geographical distribution, the appearance, which is macroscopic appearance of the appendix itself, and the microscopic appearance, which appear under the microscope. Prognosis of acute appendicitis before and after treatment, and we talk about mortality and morbidity of the pathology. As we said, it is either obstructive or non-obstructive. In obstructive type, which is the commonest type of acute appendicitis, the obstruction of the appendiceal lumen can occur due to many causes, either the hypertrophy of the lymphoid tissue due to infection, viral infection, or bacterial infection, or it is blocked by a worm, as Oxyuris vermicularis, which is present in children and so on. This obstruction will make the pressure in the lumen to build up, and the appendiceal pressure or the inside pressure of the appendix will be increased, and this will lead to jeopardize of the blood supply to the appendix, will lead to ischemia of the appendix, and oxygen delivery will be less, and the tissues will be hypoxic, and this will lead to ulceration of the appendix mucosal lining, which eventually will lead to promote microbial invasion, and at the end, inflammation of the appendix will appear. We have 4 types of inflammation. Either it's a catarrhal one, an early one, or it will be a chronic one, or due to mucus collection and obstruction, pus will form inside, and it will form a mucocele or a pustocele, and at the end it will rupture. Etiological factor, as we said, of acute appendicitis, either obstructive causes or non-obstructive. Obstructive causes either by a feculis or a stricture in elder patients. It will be due to a stricture because of fibrosis. Non-obstructive is due to bacterial proliferation. Mixed growth commenced is streptococci, streptococcal fecalis, and E. coli are the most common. As we have said, intestinal parasite like Oxyureus vermicularis can obstruct the lumen of the appendix. Tumor in elderly patients like carcinoma of the cecum, it can happen. Fibrotic stricture in older age can occur and lead to obstruction. Non-obstructive causes, as we said, bacterial spreads through the blood, either hematogenous or from the cecum. Viruses can cause inflammation. This is why you find it in children who are having repeated tonsillitis, and the lymphoid tissue of the gastrointestinal tract will be affected, and if it affects the appendix, it will cause some sort of obstruction and catarrhal appendicitis. Parasites, as we've mentioned, Oxyureus is the commonest thing. Diagnosis. Diagnosis is composed of history, examination, and investigation, and after that is the treatment. How to diagnose? History of acute appendicitis will start with pain. It could be early around the umbilicus or epigastric, and it will be later on referred to the right iliac fossa. The first pain is a referred pain due to the common supply from D10 to both areas, to the umbilicus and externally, and to the cecum. In that area, it is the root is root 10. Examination is still in the history. Pain, which is starting around the umbilicus and migrate to the right iliac fossa. Then the patient will be anorexic, he can vomit, and he will have malaise, low-grade fever, and he will be feeling unwell. Sometimes there is diarrhea, sometimes there is constipation. Examination may show low-grade fever. Temperature will be around 37.7 or 37.8. Abdominal examination will show tenderness, maybe all over or maximum at the McBurney's point. A patient will be tachycardic, will be having high respiratory rate. Investigation will show the blood work, will show leukocytosis, urine might show pyuria or hematuria. In this context, the pregnancy test is important because it will come in the differential diagnosis of acute appendicitis. As we've said, the pain started at the gastric area and then around the umbilicus, and then will be shifted to the right iliac fossa, malaise, anorexia, vomiting, fever of low grade, constipation, and sometimes diarrhea. Objective signs, as we said, tenderness in the McBurney's point, and it may be associated with a rebound. Positive rough signs may be positive obturator and source signs and elevated temperature. What are the clinical manifestations? Local tenderness is elicited at McBurney's point when pressure is applied, rebound tenderness, production or intensification of pain when pressure is gently applied and then released. Major symptoms: abdominal pain may be in more than 95% of acute appendicitis, anorexia may be in more than 70%, constipation less commonly is 4 to 16%, diarrhea is 4 to 16%. These things, the history, examination, and investigation was grouped together in a score which is called Alfredo score, and it is done by an American surgeon from California, and he grouped some of these symptom signs and investigation, and he came with a score of 10. Alfredo is an American surgeon, grouped the signs and symptoms and investigation in a score which is called Alfredo score. He gives the migration pain 1, anorexia 1, he gives the nausea 1, and tenderness he gave it 2, and rebound is 1, elevated temperature is 1, leukocytosis he gave it 2, and shift to the left in the white cell count as neutropenia. Total of 10. It is a clinical scoring system used to help the clinician in the process of diagnosing acute appendicitis. What are the investigations to be done in acute appendicitis? Blood work, basically CBC will show some leukocytosis. Urine might show pus cells or hematuria. Pregnancy test, if it is positive, it will. If it is negative, it will exclude causes due to pregnancy. Imaging, ultrasound, will show a peristaltic, non-compressible, dilated appendix more than 6 millimeters in the diameter. And it will show distinct appendiceal wall layer, and it can be thickened. And if there is fluid outside, it shows a fluid collection, and enlargement of the appendix can be there. Radiology is less sensitive and less specific in acute appendicitis, but it may show a feculus that is obstructing the lumen of the appendix, and it may show stone in the ureter or stone in the bladder that will mimic the signs and symptoms of acute appendicitis. CT scan is commonly done in the West, maybe in every case, but here, as we have said, the diagnosis of acute appendicitis is clinical, and it will be helped by investigation like CT scan and MRI. CT scan will show the tissue which is inflamed and will show the peri-appendicular collection, and it will show the thickened wall, and it will give you the clue to the acute appendicitis. This is a CT of acute appendicitis, which is clear that there is fluid there and there is clear collection, and the appendix is thickened. Treatment of acute appendicitis, simple uncomplicated acute appendicitis treated usually by appendectomy, either open appendectomy or laparoscopic appendectomy. There are some complications. Appendicular mass is treated conservatively in the first few days, and in 6 weeks' time it will be in need of appendectomy. This is how the laparoscopic appendectomy is done. They will open 3 openings. The one for the camera infraumbilicus or supraumbilicus, one port in the right iliac fossa, the other one in the left iliac fossa, and then the procedure will go on. What are the complications of acute appendicitis? As we have said, the blood supply is the appendicular artery is end artery, and it will be prone to ischemia. And if there is ischemia of the appendix, perforation inflammation can occur, and collection of pus inside and perforation may occur. And if there is perforation, if it is localized, it will be an appendicular mass. It will be localized by omentum and loops of bowel. But if perforated, it will cause peritonitis and adhesions, and later on it will lead to intestinal obstruction. Thank you very much. We are ready for sending questions for acute appendicitis, and if there are any questions, you can send them in the comment below, or you can discuss the slides and discuss the topic of acute appendicitis. You can go to Bailey and Love Short Practice of Surgery, page 353, the 28th edition. It will help you too much. Thank you until we meet next time. Thank you.